Yes, thank you very much for the kind introduction and the invitation. To be honest, as you can see here, I cheated a little bit by adding 2 more words in the title. That's because we just concluded a randomized controlled study, so I wanted to include this, and that's why I included ALS patients to the presymptomatic ALS gene carriers as well, because I think you don't always have the opportunity to show new results from an RCT, so I hope that's acceptable. But let's start as usual by showing what you already all know, that body weight and triglycerides and cholesterol are prognostic factors in ALS. As you can see here, survival is prolonged with in normal nourished compared to malnourished patients, and also patients with hypertriglyceridemia have better prognosis. And you really have to differentiate though between triglycerides and cholesterol, because as we found recently in our Swabia registry cohort, which is a very well-defined cohort, that really only triglycerides have that beneficial prognostic value, and with cholesterol it's the opposite. Higher cholesterol patients have a worse prognosis, and I am pretty confident by now that this is true, as it has been confirmed by several recent publications from other groups. So this is very important to consider. And while the detrimental effect of cholesterol is not clear at all, there are many different hypotheses around this. It's quite easy to explain the beneficial role of triglycerides, because it's a very valuable energy store. We know that carbohydrates, there's a problem with utilization of carbohydrates in ALS, so fat triglycerides really represent really good alternative to provide energy and to compensate the energy deficit in ALS. So interestingly, if you look at body composition, you can already see alterations in presymptomatic gene mutation carriers. This is all the results which are shown are from our cohort, which comprises about 75 presymptomatic gene mutation carriers and 75 controls from the same families. And as you can see here, body mass index is already reduced in the presymptomatic stage, and also body cell mass, so the amount of metabolically active cells is reduced, and the phase angle, which is also a measure of healthy cells, is also reduced significantly in the presymptomatic stage. But also interestingly, this seems to be gene specific. So if you compare SOD1 to C9orf presymptomatic carriers, you see that first the differences are quite prominent. So the alterations are much more prominent in C9orf compared to SOD1, and also SOD1 patients somehow they manage to have a normal BMI and a normal fat mass, so they don't lose body fat. So all presymptomatic gene carriers lose metabolically active cells, but only C9orf, but not SOD1, lose fat. So the etiology of weight loss, the most important factor, of course, as you know, is hypermetabolism, as it is called. So patients display an increased resting energy expenditure, which is about stable over the course of the disease, and this has been shown a lot of times. And if we look at presymptomatic gene carriers, we see something interesting, because I was expecting to maybe find this in the presymptomatic stage as well, but the opposite was true. We saw a hypometabolism in carriers compared to controls. So this could be a compensatory mechanism to counter the imminent energy deficit. This could be one explanation. It could also mirror the loss of metabolically active cells. But if you look what happens with incoming disease onset, the closer the presymptomatic carriers are to their expected age of onset, which is marked here by this line, you can see that that the metabolic rate increases over time. It's the white figure here, and becomes hypermetabolic in the symptomatic stage. So this was quite a surprising finding. So what are the causes of hypermetabolism? We all know, of course, about the hypothalamic dysfunction. There are a lot of very important publications by German and also French groups. And but I wanted also to highlight the mitochondrial dysfunction, which is also important, I think, in this regard, as it has been shown that the enzyme complexes 1 and 4 are severely disturbed in ALS. We have reduced ATP levels and also reduced oxygen consumption in motor neurons. All that has been shown multiple times. So it makes a lot of sense to think about this also as a therapeutic target. So now I will show two clinical studies. One you might already know, it's the LibCal-1 study that concluded in 2020. It was a large randomized controlled study in which we applied a high caloric fat-rich supplement to counter this energy deficit and to fight catabolism and weight loss in ALS patients. And we found very promising results. So we found a large survival benefit in fast progressing patients. Unfortunately, we missed a little bit of statistical power to show the survival benefit in the whole study population. So this was the primary endpoint. This was a bit unfortunate. But we also saw that the ALS-FRS decline was slowed down in the intervention group compared to placebo, which remained stable. And we also saw that neurofilaments went down. So because we did not confirm the primary endpoint, we tried to do a follow-up study, and we were very happy that the DFG funded another large study, which is currently taking place in the German ALS network. And we used the same intervention, but we massively increased statistical power by first excluding slow progressors. We also included a much higher number of patients, as you can see here, 400 instead of 200. And this study is currently ongoing with already 249 patients included. And last, I would like to show you the results of the study I have mentioned in the beginning. This is another randomized controlled study which we have just concluded. It's a monocenter study which followed the keto idea, which is also discussed very frequently. And what is keto? Ketogenic diet, as you might know, is a fat-rich, low-carb diet. And that means the body has no glucose. And what happens then is that ketone bodies are produced from fatty acids in the liver. And ketone bodies are able to pass the blood-brain barrier. There's a specific transporter and can be utilized in the mitochondria. Ketone bodies provide more ATP per mole compared to glucose, and they are known to improve the complex 1 of the respiratory chain. So exactly what we would need in ALS. So also there was already an animal study which showed improved motor function and gain of body weight in SOD1 1 mice. So really a promising candidate, and somehow no one followed up on that animal study, which is very old, from 2006. But we were able to conduct this randomized controlled study with 76 patients randomized into 2 groups. One of them received ketone bodies orally. We did not perform a genuine ketogenic diet. We directly gave them the ketone bodies for practical reasons. And we compared this with placebo. And we followed up those patients over 6 months and used NFL as the primary endpoint. NFL is really the right outcome parameter here, I think, because it is possible to show an effect in a shorter time frame compared to clinical endpoints like ALS, FRS, or survival. And what we found, this is really fresh material here, is that it actually worked. So we saw a slight reduction of NFL compared to placebo, which was statistically significant, and we also saw a stabilization of body mass index. Really, those effects are not extremely large, but in the LIPCA study we saw that even slight changes of NFL might have big clinical effects, and whether this is true for ketone bodies, that I think we have to see in a follow-up study with a longer time period in which we see the effects on survival in ALS, FRS. But this is promising, I think. And also, if you look in the subgroups, we see that the effects are larger in patients with high baseline ALS, FRS, so earlier patients, and also in patients with higher baseline NFL values. So the effect is larger in fast progressors. So you see a pattern here. It's the same pattern like in the LIPCA study with the high-fat, high-caloric supplement. So 2 interesting therapeutic approaches based on metabolic alterations. To summarize, metabolic alterations are prognostic factors and therapeutic targets. High BMI and triglycerides are positive prognostic factor. High cholesterol is a negative prognostic factor. We find those metabolic alterations already in presymptomatic gene carriers. We see reduced mass of metabolically active tissue, and in C9orf, but not SOD1, also reduced fat mass. This might also contribute to the better prognosis of SOD1 patients, and at least in Europe. And what we did not find was the hypermetabolism, but we found a hypometabolism instead, probably or possibly indicating a compensation mechanism. And clinical studies targeting the metabolic alterations, I have mentioned the LIPCA ALS1 study, which is already published, the LIPCA 2 study, which is ongoing, and I have shown you the first results of the Keto ALS study. So both high-fat, high-caloric interventions as well as ketone bodies, or possibly ketogenic diet if you can implement it in ALS, which can be difficult, seem to be promising therapeutic candidates. So thank you very much.
Thank you, Johannes, for your talk. Is there any questions?
A very nice talk. I can agree more. But high fat, we may need to distinguish the different type of lipids.
Right.
I'm sure you know that.
Yes.
Well, this is an energy war. It's not by chance that the motor neurons degenerating because it's the highest consumption of oxygen in the body and
Yes.
the highest metabolic need. So what you present make a lot of sense. But maybe starting with omega-3, omega-6, maybe it's more complex. We observed also that there are different subtype of cell death, notably the new one, the ferroptosis, who shows that if you fill the body with arachidonic acid, you worsen the situation. So on one hand, you may need higher lipid, incorporation for as you said, the triglyceride to fuel the energy metabolism. But on the other hand, some lipids may worsen the cell death.
Yes.
And then at the end, as you show, the cholesterol
Yes.
rise up because it's a consequence of destructuration of the cell membrane.
Yes, I couldn't agree more to everything you said. Yeah, right. So first, motor neurons are, of course, very dependent on energy. They are the most energy-consuming cells, I believe, in the body. So, yeah, this might be also a reason why they are so vulnerable to the disease process, of course. I also agree to your comment regarding the composition of fat. So this is not enough investigated. But the exact composition of fatty acids, long chain, middle chain, omega-3 and 6 fatty acids, this all is probably very important because I focused on the energy here in the talk, but also there are many excellent works which investigate the neuroprotective effect of fatty acids and different different constellations of compositions. So
we should consider a German-French translational clinical trial for that, I think, regarding this aspect.
Okay, great talk. So I would like to ask you a general question, because the thing is, for high-fat diet, even ketone diet, it didn't really change the fact that the mitochondria have problems. And how you address this part? I mean, will that be a limitation for this diet treatment?
So I mean, even with ketone bodies, you cannot circumvent the citrate cycle, right?
Yeah.
So but the advantage what you have is that you just get more energy out of it. So if you consider that a share of your mitochondria is still working, you might be able to provide more energy with the remaining reserves. That does not target the cause of the disease. It's a symptomatic therapy, so I would consider it. So the effects which you can have are naturally limited. Yeah, you cannot cure the disease by applying a high caloric supplement or by providing more fuel, but I think you can slow down the disease. That is what we are aiming for.
Mm-hmm. What about the high glucose diet? Did you think about this?
I think this, we have also considered glucose, but there are quite a few publications highlighting that there might be a problem with glucose utilization in ALS. And we also we compared different types of caloric supplements. We also saw in another study that patients receiving the same caloric intake via carbohydrates, they do not maintain their body weight as well as patients receiving fat. So fat really seems to be the better source of energy in ALS.
Yeah, thank you.
We don't have a lot of time remains. So
Okay, quite quickly then. When we did the very first metabolic study in SOD1 mice, at the end, they had no triglycerides left, virtually, to that extent. So it was really quite very impressive. But there's one thing for your ketogenic diet, it's via giving substrate via MCT1. The natural substrate is lactate, and the problem is that when you have movement disorders in the first denervation, you're going to lose the main energy source coming from the periphery. Admittedly, most of it comes locally, but coming from the periphery to motor neurons and oligos. And I think that's underestimated in the way in which you could possibly boost a ketogenic diet with lactate.
Yes, I agree. And I can also add another problem. if you apply ketone bodies directly, you still have glucose. So we don't really know if the cells utilize those ketone bodies as well as if you would conduct a genuine ketogenic diet. So maybe the better approach would really be to do a ketogenic diet in ALS. This is difficult for practical reasons because patients have dysphagia and they have reduced choice of food, and the disease is burdensome anyway, and they have also give up some quality of life by restricting their food choices. So we really tried that, but it was difficult to do, at least in orally feeding patients. But we are aiming to do something like that in patients fed via PEG.